Okay, just a couple of things. So like I told you yesterday, I uploaded under the gout and RA my lecture material from last year. So if you want to see what I put on slides, I don't know if it's going to help you or not, but it's there if you want it. Under, I think it's like pulmonary function is the name of the heading. Pulmonary function, like testing. I don't know what I named the heading on your D2L site, but it's something like that. I put the lectures that I also gave to the P2s and the pulmonary IS over like different types of inhaler, pros and cons, and pulmonary function testing. So that material's there if you want to review it. Tomorrow in patient assessment, we'll do lecture in the morning, and then when we go to lab, there's actually this like inhaler checklist that you guys are going to have kind of make cheat sheets for yourself about like counseling points on the different types of inhalers and you know, which ones can use a spacer, which ones have to be shaken well before you use it, that kind of stuff. So it kind of be like your own little personal cheat sheet to study off of. So you might want to refer to that lecture material to be familiar with that, or if you need help filling out your sheet. And then we'll have all the inhalers available tomorrow in lab for you guys to play with, like put your hands on. Don't inhale out of them, they're disgusting. They've been touched by lots of grimy hands over the years, and they're full of like lactose powder, so somebody might have like an asthma attack, and we don't have a real inhaler to save you, so you probably shouldn't do that. Okay, questions? We good? Questions about OA from yesterday? All right, so what we're going to do is, because the way I like to do asthma and COPD is we kind of like churn through the lecture material, talk about the stuff, and then I'll turn you guys loose to do some like patient case kind of in-class activity things to kind of really make you think and apply the material, because that's when you're like, oh, I thought I knew this, but I really don't. And so our goal today will be to kind of get through this material as quickly as possible, and then kind of turn loose into groups either at the end of today or first thing tomorrow in class to do the group activity. So, but if I go too fast, please stop me, okay? There's tons of things posted about asthma out there. There's the EPR3 guidelines, which are like the National Heart, Lung, and Blood Institute guidelines for asthma. The problem with those is they were updated in 2007, so they're old. And then the GINA guidelines, I posted those as well, and they were actually updated in February of this year, so they're much more current, and they're also easier to read. And so you might want to take a look at those. We're going to talk about both sets of guidelines today. There's minimal differences between the two, but we'll kind of talk about some of the nuances of like how that might change the way you would take care of a patient with asthma. Typical objectives: identify asthma symptoms, know how you treat asthma patients, know when to change therapy for a patient with asthma, or redirect based on their clinical situation. All right, so let's get started. So asthma. Lots of people have asthma. That's the bottom line. And of those that have asthma, lots of them have asthma attacks every year. So it can become an acute problem very quickly. And people present all the time to the hospital and need to be intubated or even die from asthma attacks if they're not controlled. So it's a serious problem. Boys tend to have asthma more frequently than girls. But then at puberty, that switches because estrogen and other female-type hormones actually cause you to be more hyper-responsive in your bronchioles. So lots of women tend to have asthma, but boys are more typically the ones that grow out of it. Anybody ever heard, oh, I had asthma as a kid, but I grew out of it kind of thing? That usually happens more for boys than it does for girls. And actually, one of the funny things, if a woman comes in and she's like, I'm having like lots of asthma symptoms, your first question should be, are you pregnant? Because that's a really quick indicator of like a change in asthma, as pregnancy can cause a worsening of asthma in women pretty quickly. So just always remember that. Minorities have a disproportionate share of asthma problems, and they're actually more likely to have negative outcomes, hospitalizations, even deaths secondary to asthma. No one knows why. No one knows if that's a genetic component or if it just has to do with in general, a socioeconomic component, you know, inner city versus suburbs versus out in the country kind of thing. So, but that is true. So asthma basically is made up of two things. One, airflow obstruction, that's reversible. So we're going to talk about COPD coming up next week, and COPD is non-reversible obstruction, but asthma has a reversibility to it. And bronchial hyperresponsiveness. This is like the key component of asthma. So for this delicious Chick-fil-A on the front row, if I had an allergy to Chick-fil-A and I had asthma, it's more likely to induce a bronchial response in me and cause my bronchioles to constrict than just random Joe Schmo off the street that happens to walk by the same trigger. So that's why, you know, being outside and the allergy from the leaves or the pollens, even like certain smells, like people who are like, oh, your perfume is just driving me crazy, it's, you know, causing a problem, that's more likely to happen in asthma patients. So bronchial hyperresponsiveness is a key. There's lots of immune cells involved. Depending on certain patient-specific factors, you can have different immune cells that predominate in those patients. So some patients may have more eosinophils in their lungs. Other patients might have more neutrophils in their lungs. And sometimes that actually is an indicator of how severe their asthma is. I don't expect you guys to know that, but it's kind of a fun fact. And the cool thing is, all these immune cells and these inflammatory mediators have become really hot topics for new drugs in asthma. So probably in the next, 15, 20 years, we're going to see lots of new drugs that are coming out that target these cells or mediators to help treat patients with asthma. We already have one that targets IgE that we're going to talk about today called Xolair, or omalizumab, and it's an antibody that targets IgE and actually prevents it from binding to cells and then releasing inflammatory mediators. Super expensive, but super effective for some patients. So this is just a diagram. So people who have normal airways, you can see kind of the diameter of their bronchioles. It's nice, it's big, there's no obstruction. But then people who have asthma, even at baseline, even at their best, their bronchioles are kind of inflamed, the cells hypertrophy, that the lumen of their bronchiole is more narrow than the normal person that doesn't have asthma. And then when that person has an asthma attack, it's kind of like the same thing on steroids. It just gets much worse. And you can see how much smaller the lumen of their airway is in the far right corner of that picture. So what causes asthma? We have no idea why people have asthma. Pretty much that's the quick and dirty of it. There are people who think it's the hygiene hypothesis. Has anybody ever heard of that? Basically meaning that we keep babies too sheltered. We should expose them to more things, more allergens and more germs. Because just like everything else in your body, for something that's positive for inflammation, there's also something that's negative for inflammation. So Th1 cells are negative inflammatory cells, and Th2 cells are pro-inflammatory cells. And so the theory is that when you keep these babies too sheltered, they don't develop their Th1 cells normally, and they have an overexpression of Th2 cells, and that causes them to be more responsive to allergens that they really shouldn't be that responsive to. Genetics has a huge role in asthma. So people who, if one twin has asthma, the other twin is also likely to have asthma. If siblings, if parents both have reactive airway disease, their children are more likely to have the same problems. So there's a huge component that goes into actually your genetics. Now, this may or may not be a new word, I don't know, but atopy. You'll hear people talk about atopic asthma or atopic conditions. And that's just basically a genetic predisposition for having IgE-mediated responses to common antigens. So these patients that we were talking about before, you may walk into a room and someone's used a cleaning supply and you're fine, but that person that has atopic asthma may walk into the room and they have an IgE-mediated response and they have an allergic reaction just because they're exposed to that antigen. It's genetic. for lots of people, but this is a really, it's a negative predictor for outcomes in asthma. So patients who have atopic asthma or allergic asthma are more likely to have poor outcomes with their asthma. So that's a big thing that we watch for and look for in our patients to see if they're having an allergic component. Long-term consequences. Overall, if this goes untreated, you're going to have fibrosis of the lung tissue. You can have long-term, that reversible obstruction can then become irreversible. So these patients can then go on to have COPD on top of their asthma later in life. And we really don't know why the lungs remodel the way they do. You know, you guys just talked about heart failure and how over time the heart remodels and it becomes, you know, thick, and the muscle cells kind of hypertrophy, and they're not as efficient as they once were, and it becomes fibrotic. It's very much the same thing with the lungs and asthma. Okay, over time, because of those negative insults, the lungs kind of change. These patients also have mucus overproduction. So lots of these patients will have like mucus plugging. So they'll get these thick secretions that will like plug their bronchioles. And lots of patients that come in and die from asthma attacks on autopsy are found to have mucus plugs in their lungs. So that's a common reason for patients to die from asthma. And then that, like we said, the hypertrophy and the hyperplasia of those cells is a lot of the reason why these patients have that bronchial hyperresponsiveness over time. So what do these patients look like? Well, it varies. So there can be a patient with asthma that lives a totally fine, normal life. They play sports. You know, they have no impairments in their daily activities. And then you can have another patient with asthma that can't walk from here to the door without having an asthma attack. It can vary between patients, and it can also vary at different parts in their life. So, you know, you could have, just like we talked about earlier, you could have a lady that she's well controlled with her asthma and then decides to become pregnant, and while she's pregnant, her asthma worsens. Symptoms will wax and wane over time, so every patient with asthma will go from sometimes having very severe symptoms to having less severe symptoms, and we don't always know what causes that. And asthma can also be, so that last bullet point there, diagnosis is best done by patient history. So asthma can look like other things. So poorly controlled GERD can look like asthma. Okay, poorly controlled GERD, if patients are having reflux into their esophagus, they may present with similar symptoms of a patient that has asthma. Obstructive sleep apnea can look like asthma. And so making sure that you ask the right questions and you actually make the correct diagnosis is really important. Okay, common symptoms. So I've kind of, most of this is probably like a no duh, but just in case, I put it all up here. So for chronic asthma, the thing that most people complain of with asthma, obviously, is shortness of breath. They can have wheezing or tightness in their chest pretty often. They usually will have, or they can have a nocturnal cough. So when they lay down at night, they just can't seem to stop coughing. And that could be because they have reflux, or it could be because as your circadian rhythm changes throughout the day, you have different releases in inflammatory mediators during that 24-hour cycle. And some of those inflammatory mediators get released at night. A common kind of co-condition that we see with asthma oftentimes is like eczema or other dermatologic conditions. Those are closely linked. And then these patients typically will have symptoms that get worse with cold air or with exercise. We call that exercise-induced bronchospasm, and we'll talk about that and how you treat that and all that fun stuff. But, you know, cold air can be really hard on these patients if they have to breathe it in the wintertime. Acute asthma is all this stuff kind of amplified. So they can become tachypnic, they're breathing really fast, they're tachycardic. They'll use their accessory muscles to breathe. So people who start to use their neck muscles, when they start to breathe in and they start to use these muscles, that's your accessory muscles. And that's a sign of a patient who's pulling really hard to breathe for air. They usually can't speak many words between breaths, and they might have like skin color changes. Like their lips will turn blue, or they'll turn really pale. Let's see, what do we need to talk about here? Oh, So asthma, it's chronic, it's always there, and then on top of that you have acute exacerbations, which is pretty much true for every disease state, right? You talked about chronic heart failure, and on top of heart failure that chronically is always there, that has symptoms, you can then have acute exacerbations. It's the same thing with asthma. Exercise-induced bronchospasms, we just kind of talked about that. Usually this happens to people who are, exercising, especially in cold, dry air. Winter sport athletes or people who live in colder temperatures, or people who live in Florida and they're just, not used to temperatures below 60 degrees. That can also be a problem for those people as well. Or, any other southern climate. Not picking on Florida specifically, go Vols, but nocturnal asthma. So this is usually something that gets worsened a lot with other comorbidities, and they're kind of linked together, like we talked about. So people who have GERD or sleep apnea, oftentimes their asthma will get worse at night. Risk factors. Okay, so you guys need to pay attention here, because there's a couple of these I definitely want you to be able to pick out and know. So viral respiratory infections is a huge independent risk factor for an acute increased severity in your asthma. Okay, we talked about kind of socioeconomic status and environmental exposures. One thing that you may not think about, but like stress and depression, so emotional changes oftentimes can induce asthma symptoms or acute asthma attacks in patients if they have the disease. Pregnancy, we talked about, that kind of goes along with, female hormones. Any kind of allergies, obviously food allergies, environmental allergies. Obesity is another one. We talked about GERD too. But obesity kind of is an independent risk factor for asthma, and then a more severe asthma on top of that. So lots of children who are morbidly obese, oftentimes if they'll just lose body weight, it will help control their asthma independent of drugs. So that's a big one. And then we have certain drugs that we give patients that can actually cause more severe symptoms with their asthma. So we have some patients who are allergic to aspirin, and when they take aspirin, it actually causes their mast cells and basophils to release histamine, and they have like an asthma attack because of that. NSAIDs, because they have a similar mechanism, can cause the same thing. And then non-selective beta blockers. You guys talked about selective versus non-selective beta blockers in the cardiology module. Those can also, in some patients, induce airway disorders or airway symptoms because of the beta receptors in the lungs. Okay. This slide is just kind of here to kind of set the groundwork for some terms that you might hear in asthma. Really what I care about is that you know that we talk about asthma in severity and control. Okay, so those are the two things that we'll talk about: how severe is your asthma and how well controlled is your asthma. And those are defined based on your level of impairment and your level of risk. So the impairment, how much does this, the severity of your asthma, how much does that impair your daily life or impair your ability to live a normal life? And then your risk relates to things like adverse effects from medications or even the risk of dying from exacerbations. So you'll hear those terms a lot. So that's just kind of there to kind of help clarify that for you. Some of the questions that you might want to ask patients relating to their asthma that they may not even think about. So like, for example, work or school that's missed. So kids that have asthma are more likely to miss school days, and the more uncontrolled their asthma is, the more likely they are to miss more school days. And so they may not even correlate those things, because it may be that a kid's having uncontrolled asthma at night and they're just a bear in the morning because they don't sleep well at night, and then mom lets them stay home because they're grumpy or whatever. And they may not even correlate that's related to asthma. So some of these things you really have to ask very clear questions, and kind of questions that you would think would be no-brainers to some of the patients to really help identify symptoms that are coming from their asthma. The other thing about kids specifically is they're really bad to self-limit. So let's just think about the kid that you have that's cute and slightly chubby and they're running around and they have asthma. I can say that because I'm a chubby kid. I was a chubby kid for sure, so I can totally say that. So they're running around and they have asthma and they're having symptoms from their asthma, so they stop doing activities that they would normally do, like running and playing and being active, because their lungs hurt. So, but they don't tell mom that, or they don't tell dad or whoever that. And then what happens is they become sedentary and they decondition over time. So then that child is more likely to gain more weight, become more deconditioned, to have more problems with their asthma. So kids are really bad to self-limit themselves in activities. So you'll have to be kind of creative when you talk to kids about things that they may or may not do because of their asthma symptoms. And they may not even tell their parents. This is kind of 4 really neat questions that the GINA guidelines put out that are easy, simple, like anybody can remember. So, are you having daytime asthma symptoms more than 2 times a week? Are you having any nighttime awakenings due to asthma? Rescue therapy needs more than twice a week, or any activity limitations. So this is like a 4-question assessment that GINA puts out that you could ask any patient in any setting, pharmacy, hospital, clinic, on the street, whatever, to kind of talk about their asthma. And they give some guidelines based on how they answer those questions and how that relates to their level of control of their disease. Okay. Goals are pretty much self-explanatory. We want to gain control, reduce their impairment, and then reduce their risk. We're going to talk a lot about the risk of acute exacerbations of lung disease throughout the rest of the module. So with COPD or asthma, either one, when a patient has an acute exacerbation, their lung function never returns to baseline. So if their lung function is here and they have an acute exacerbation, it drops. If it gets better, it never quite gets as good as it was before they had that exacerbation. So over time, it's like a chronic insult that happens over and over and over to these patients, and they can't sometimes recover from that. Okay, don't freak out. I know this looks like a lot, but I promise I'm not crazy. I don't expect you to know it all. Okay, so there are 2 ways. These are from the EPR3 guidelines. This is the classic guideline that everyone quotes for asthma. Okay, so you'll hear people discuss asthma in terms of being intermittent, okay, or persistent. Those are your 2 classifications. Either you have intermittent asthma or you have persistent asthma. And persistent asthma can be defined by mild, moderate, or severe. But it doesn't matter. It's still persistent. We're going to treat it in a similar fashion, no matter what the level of severity is. Okay? So what I would expect out of this for you guys to be able to identify is what makes someone not fall in the category of having intermittent asthma. So you should be able to identify these 4 things. Okay? So symptoms less than or equal to 2 days a week, nighttime awakenings less than or equal to 2 times a month, rescue use less than or 2 days a week, and then no activity limitations. Okay? If it doesn't fit that criteria, it's persistent asthma, and it gets treated differently. Does that make sense? So what would happen if I said their symptoms are 1 time a week, they use their short-acting beta agonist 1 time a week, but they're having nighttime awakenings 5 times a month? How would you define that patient? Persistent, right? So even no matter what, they always default to the most severe category. So if some of those happen to be in a more severe category, or even one of those are in a more severe category, you're going to default to whatever would give that patient the highest level of treatment. Okay? Questions about this? So those are the things I would expect you to be responsible for on this material, okay? Now, when you talk about severity of asthma, that's without any long-term controller medications. So a patient walks in to your clinic, or they walk into the hospital, or wherever, and they're newly diagnosed, or they're not on any controller medications at home. That's how you determine this, severity without long-term controller medications, okay? After a patient is on a controller medication, then you're going to look at their level of control. I know, it seems redundant, but that's the way this works. So, kind of speaking the language. So again, on this one, I want you guys to be able to pick out these 4 things, which are just like the 4 things you had to pick out on the slide before this. about control. So you should be able to identify a patient that's well controlled with their asthma. If they're not well controlled, it doesn't matter how not well controlled they are. You're still going to change their therapy. Okay? But if they're well controlled, you should be able to pick those patients out very quickly. Questions about that? Seem fair? Everyone normally does very good with that, so don't let that worry you with the information. Okay. Non-pharm treatments. Pretty much everything we've talked about at this point, trying to reduce those comorbidities, control them, reduce triggers when you can through allergen exposure or maybe foods that trigger asthma in patients. But just reducing triggers alone is usually not enough to control their symptoms. They're still going to need medication on top of that if they have severe enough asthma or persistent asthma. And then don't forget your health vaccines, your routine health maintenance. So flu vaccines for everyone over 6 months of age. And then for your pneumococcal vaccine, you really have to pay attention to the scheduling for kids versus adults because that will change almost yearly sometimes by the CDC on who qualifies for those vaccinations. I think the most recent CDC recommendation is if you have a patient who has asthma and they have high-dose inhaled corticosteroids, they qualify for the pneumococcal vaccine. If they're not on high-dose steroids, then they technically don't qualify per the most recent recommendations. But, you know, that's one of those things, just always double-check yourself and look at it to see if the patient needs that vaccine. Questions? Okay. Now, some of the medications, this is kind of flip-flop. Typically, I do COPD first and then asthma, but the schedule worked out better for you guys this year to do asthma first. So in the COPD lecture material, Part 2 talks about the medications, and it talks about side effects of the medications, and also talks about mechanism of action. So if you have specific questions while we're reviewing the asthma material about like beta agonists, for example, just pull that material up. And if you still have questions, we'll obviously be covering that soon, but just wanted to make sure you knew that was there. So controller medications, okay? Here's like something you're going to hear me say for the rest of the module and for the rest of the time that you ever know me. There's two big differentiating factors between COPD and asthma, okay? COPD, the backbone of therapy is a bronchodilator, okay? Always, always, always. Those patients always have to have bronchodilators. Asthma patients always have to have inhaled corticosteroids. That's their backbone of therapy. So it would be inappropriate for a patient with asthma to only be on a long-acting beta agonist. The best thing they have to control their disease is inhaled corticosteroids. Clear? So it's a huge differentiating factor between the two diseases. They are classified, so ICS is how you'll see that abbreviated, inhaled corticosteroid. They get classified into 3 dose categories. So low, medium, and high dose, okay? And I'll give you, there's a chart, I think on the, next slide, we'll talk about that in a minute. You don't have to memorize that, so don't freak out. But you do have to know how to use that chart if you were given a question about altering a patient's therapy with asthma. We always worry, regardless of route for steroids, about side effects. So the biggest thing to remember about inhaled steroids is about oral care. So you guys may or may not know that, you know, anytime a steroid has an inhaler, or an inhaler has a steroid in it, that you have to counsel the patient to rinse their mouth out with water and spit that water back out after use. Otherwise, they get like oral thrush and infection and like breakdown of the skin in their mouth. So that's a big one. Now, I always tell, because it never fails, I'll get a patient that comes to the hospital and they'll be like, well, my purple disc inhaler, I use that when my symptoms get really bad, but my ProAir, I use that 4 or 5 times a day, every day, whether I need it or not. And they'll get their inhalers confused, and they won't know which inhaler does what. So my safe thing is I just tell them after every time you use an inhaler, rinse your mouth out. Just that way, in case they get confused about their inhalers, you know, they can at least be safe and know that they're taking care of themselves when they have a steroid inhaler. When you talk about the equipotent doses for patients, now this is for adults. There are different recommendations for children. I don't really have you guys focus a lot on children specifically for asthma because Really, the only difference in care for those patients depends on the FDA recommendations and what we know about using those drugs in that population. But across the board, asthma is treated very similarly, depending on your age. So here, the thing to remember about your different doses is this is per day, okay? Oops. So if you are on a low dose fluticasone, then your total dose of steroid for that day is no more than 250 micrograms. It's not per inhalation. Okay? I'll give you guys this chart for the exam, so like I said, you don't have to worry about memorizing it. I still look it up every time I look at steroids, so it's not worth committing to memory. You just have to know how to use it and where to find it if you need it. Questions about steroids? Okay, so one kind of interesting thing about steroids in asthma specifically is we think of asthma as like a stepwise disease, a stepwise approach, right? So if you have somebody on low dose steroids, here's no steroids. Okay, so when you add low dose steroids, you step up their level of control to some degree, okay? When you increase from low dose steroids to medium dose steroids, that step gets more narrow, okay? So they don't get double the benefit by going from low dose to medium dose. It's less beneficial. And then when you go from medium to high, the change in benefit is almost negligible. So all you're doing for those patients in asthma is you're increasing the risk of side effects, but you're not really giving them any more effect. That's a really important concept because everyone's gut reaction in asthma is, oh, we'll increase their steroids. And they still don't have any control, and it's, we'll increase their steroids more. And clearly it's not working for them at that point. So remember that your steps are not equal between your doses. Does that make sense? Okay. Leukotriene modifiers, you guys probably see these a lot. So montelukast or zarfilikast are our leukotriene receptor antagonist, and then Xylutin is the 5-lipoxygenase inhibitor. All these work. Leukotrienes can induce bronchospasm or other inflammatory processes, so we try to block those, and that's how these drugs work. They can be considered alternate treatments for patients who have persistent asthma, but no therapy is more beneficial for a patient with asthma than inhaled corticosteroid. So these are really useful for maybe someone who is just totally I'm not going to use an inhaler, I don't care what you say, I'm not ready for that yet. So you might start out by trying to recommend one of these agents instead. They can also be really useful sometimes for children who have very mild asthma, but you don't want to expose them to, a steroid at that point, or they can't use a steroid for whatever reason. Let's see. These are more preferred in young kids as opposed to older adults. So in people over 12 years of age, the recommendation is if they need something added to their steroid, it should be a long-acting beta agonist. That's the most beneficial for those patients. So the most benefit we see in these usually happens in young kids, and that's where you'll more often than not see them if we're using them to treat asthma. Xylutin gets limited in its use quite a bit because it has quite a bit of liver toxicity as a possible side effect, to the point of fulminant liver failure. And that's not good. So it's not only is it not used as often, but it also is not recommended in children because it's not been studied in that population. Headache, super common side effect for all these drugs. And there's actually a lot of new interest and new reports of neuropsychiatric effects. So lots of people are giving this to their children, and their children are having bad dreams at night, waking up with night terrors. That's a common side effect. They're having behavioral problems after they start these. They're more aggressive. They're more irritable. So those are some of the things that you might counsel mom or dad to look for if they're starting these medications in their kids. Another fun fact about these medications is they should be counseled to be given in the evening. okay? Because that, again, goes back to that diurnal pattern in your circadian rhythm, and leukotrienes are more likely to be released in the evening. And so if you're going to counsel to give these medications, then usually it's going to be, you know, with dinner or at bedtime. Long-acting beta agonists. These are great controller medications, but you can't ever use them alone for asthma patients because they have to have that steroid backbone in their regimen. You guys may or may not have heard about all the drama around long-acting beta agonists and in asthma and increased risk of sudden cardiac death in patients with asthma. So there's this huge push, or there has been, in recent years, that if you have a patient on both a steroid and a long-acting beta agonist and they're well controlled, it's like we got to get them off the long-acting beta agonist as fast as possible. We don't want to use those any longer than we have to. But that's kind of been debunked. So we're learning like new evidence that tells us that long-acting betas are actually fairly safe as long as they're given in combination in one inhaler with the steroid. The studies that showed that long-acting betas had an increased risk of cardiac death in asthma patients, the flaw in those studies were that they gave patients 2 inhalers. So they would give a patient an inhaler that had their steroid in it, and they would give them another one that had their long-acting beta in it. And which one of those makes you feel better immediately? The beta, right? So the long-acting beta is going to cause immediate bronchodilation. The steroid is not something that you perceive. It's not something that you feel like immediately. You don't take a steroid inhaler and you're like, oh gosh, thank goodness I finally got my steroid dose in for the day, right? So those patients had a poor adherence rate to their inhaled steroid, but they were very adherent to their long-acting beta agonist because that's what gave them relief. And so the theory is that those patients had more death because they weren't on an adequate controller medicine with an inhaled steroid with the long-acting beta. So all that story is to say that if you're going to give somebody access to a long-acting beta with asthma, it needs to be in a combination inhaler. You guys know what our combination inhalers out there are? Symbicort, right? What's in Symbicort? Does anybody know?
Budesonide formoterol?
Yeah. So budesonide formoterol. Okay, Symbicort is an MDI. Oops. Metered dose inhaler. What else do we have?
Advair.
Advair, thank you. What's an Advair?
What is it? Salmeterol. I think this one.
And that is a dry powder inhaler. This walker's dying on me. What else? Dulera. Yes. Ever dispense Dulera or see it out there? What's in Dulera? And Dulera is a MDI. Can you guys see Advair and Symbicort okay? Do I need to write those darker? Good? Okay. So this is going to be important in a minute. Well, it's going to be important for the rest of your lives because you're pharmacists, but it's specifically going to be important in a minute because we're going to talk about why that makes a difference, okay? Let's see. And actually, it's going to be the next bullet point. So not only, long-acting betas should not be used for like rescue or quick relief for patients. However, formoterol is actually changing that, okay? So you see here we've got 2 agents that their long-acting beta agonists are formoterol and the other one is salmeterol, right? Formoterol has an onset of action of less than 5 minutes. Very similar to albuterol, okay? Like salmeterol and some of the other long-acting beta agonists, they actually don't have an onset of action for up to 20 minutes. So they're not very good for like acute relief because, you know, somebody calls 911 and then the EMS walks in and they're dead with their Advair inhaler in their hand, right? Because they tried to use their Advair inhaler and it didn't work fast enough, okay? But formoterol has a really quick onset of action. So actually now there are studies going on, and it's already approved in Europe, and it's used this way all the time. So they'll give a patient a Symbicort inhaler, and that's the only inhaler they have. So they use it for maintenance, and then if they get short of breath, they use it for rescue therapy. So it's a one inhaler regimen, and it allows the patients to titrate how much they need over and above their normal maintenance regimen. Versus traditional would be like an Advair plus albuterol. So they would use their Advair for maintenance. They would use their albuterol then for like rescue relief. So they would have 2 inhalers. The benefit in being able to do that one inhaler regimen is that as they increase their use of their beta agonists, they're also acutely increasing the use of their steroid. And steroid is what prevents exacerbations and helps treat symptoms. So they can like self-titrate the use of their steroid if they have that one inhaler regimen. It's currently not recommended, it's not bad, it's not approved for use in the United States. But I would probably bet the farm that within the next 5 years, this is going to be an approved use for formoterol-based regimens only. Okay, it's only if it has formoterol as a long-acting beta agonist in it, not the other ones. And the benefit here is inhalers are expensive, right? What's a copay on an inhaler usually? It's usually like a brand copay, right? So they're super expensive, so lots of patients can't afford more than one. And so if you could give a patient one inhaler and they could get all the therapy they needed out of it, it would be a huge cost savings for that patient. And we would know they're getting their steroid. Questions about that? That's a big point that I want to make sure is very clear, because that's probably going to be something that in the first 5 years of your career is going to be like a huge asthma thing. Let's see. We talked a little bit about the black box warning. There is still a black box warning for increased incidence of asthma exacerbations and deaths with the use of long-acting beta agonists. Your boards are going to ask you for things that are like black box warnings. That's the kind of stuff they're going to ask you, black and white things on your NAFLEX, okay? So you need to know that's a black box warning traditionally, but like we talked about, and like it's kind of on here, there was a meta-analysis in August of 2012 that actually contradicted that warning and showed that people who took a long-acting beta in addition to their steroid actually had better outcomes than patients who were only on a steroid, and no increased incidence in death. And then the GINA guidelines that I told you were just updated in 2014, so they have all this new information that were not available in the EPR3 guidelines from 2007. They actually come out and say that you should not discontinue long-acting beta agonists in adult patients because it leads to a worsening of their disease and more risk of exacerbations. Methylxanthines, what drug is that? Theophylline, right? Methylxanthine. Basically, the only time we ever use theophylline is if, one, we've pulled everything else out of our pocket and nothing's working for that patient. Two, if they can't afford an inhaler, which in this country is really almost unheard of because usually there's some kind of patient assistance program that we can get access to an inhaler. So typically you'll see this in like, Caribbean countries or Africa, South America, places that are kind of more third world that don't have access to like patient assistance programs. But the moral of the story is theophylline belongs in a museum, and we really shouldn't be using it anymore because it's a bad drug for most patients. It's not that it has its purpose, but we have lots of drugs that work way better than theophylline and way safer, so we really shouldn't be using it routinely. Oral steroids, sometimes if patients have an acute exacerbation or they present with really, really, really severe symptoms, like they present with an exacerbation to the hospital that's severe enough that requires us to intubate that patient and breathe for them for a little while, and that happens a lot. I see that quite a bit in patients in the hospital, especially younger kids. Sometimes in those patients we'll actually give them some oral steroids for a while to kind of help bridge the gap. So you guys know you talked about like bridging therapy with anticoagulants. You might give them like an injectable while you're bridging to warfarin or something like that. Think of this in a similar fashion. So if a patient comes in and they're on no therapy for their asthma and they have to come up with an acute asthma exacerbation and you start an inhaled steroid, it's going to take a while for that steroid to become active in that patient, like full effect a couple of weeks even. And so oftentimes for those patients, we'll bridge them with a short course of an oral steroid to make sure that they have that anti-inflammatory property on board while their inhaled steroids kind of getting up to speed. Lots of asthma patients will have like a PRN prescription on hold at your pharmacy that they might call you and say, I need to fill that prednisone prescription that I brought in last week. And that's based on kind of their self-care plan or their asthma action plan that we're going to talk about a little bit over the next couple of days. And they have like guidelines for when they use that. Overall, though, we don't want to use long-term oral steroids for patients because all the side effects. That's the reason we don't like to use steroids in everybody, right? We talked a little bit earlier about Xolair or omalizumab. This is that monoclonal antibody I was telling you guys about. Has anyone ever seen this administered? Know anybody that gets this? They use it. You know somebody that gets this? Yeah. Do you know kind of how they have to, what the process is they go through to get it?
I did it at like a Medicare Part D. Someone had it, and so he goes to like the doctor every month and gets it injected like IM.
Yes. Yeah, so Xolair, the VA does this a lot for their patients. You have to, it's one of those things, it's just like getting an allergy shot because it can cause an anaphylactic reaction. And so these patients have to go into like a doctor's office or a clinic that's equipped with like life-saving equipment, you know, a crash cart, ability to like an AED to shock someone if they went into anaphylactic reaction, those kinds of things. And they go in, they get the injection. And they have to usually sit there for an hour or two to make sure they're not going to have a reaction to that medication before they can leave. So it's really inconvenient for the patients to have to do that, but it works really well for lots of patients who have poorly controlled asthma. We usually only reserve this for patients who are already on that high-dose everything and they're still not controlled. And if they have allergic asthma, they're more likely to respond to this than if they don't have an allergic component to their asthma. You're right, so it's given actually sub-Q every 2 to 4 weeks. And we dose it based on their levels of IgE in their serum. So that gets checked throughout therapy, and depending on their level of IgE, we adjust their dose. And then also based on their body weight. Super expensive. A dose of Xolair usually runs, depending on body weight, anywhere from $1,000 to $1,500. Currently, you know, it may get cheaper as time goes on. We talked about that box warning for anaphylaxis, so you have to make sure they have emergency equipment available. And then this is approved for kids and adults over 12 years of age. Therapies that are currently getting reviewed for roflumilast, which we'll talk about with COPD. This is brand name Daliresp. Has anybody ever dispensed that one? It's a tablet. Once daily tablet, okay. It's a PDE inhibitor, okay, kind of like the Viagras of the world. It inhibits a PDE that then can help increase. If you inhibit PDE, you inhibit the breakdown of cyclic AMP, and then that cyclic AMP then helps keep the bronchioles dilated. So there's some current look and research into using that in asthma patients. And then mepolizumab, this actually was there was a trial that just came out in New England Journal in September about this one. It's another antibody, but it's specific for interleukin-5. It's one of those ones we had on the very first slide that I said were hot topics for drug therapy. So comparing that to placebo, there was a 50% reduction in exacerbation rate for those patients. So this is now moving on into like non-inferiority studies and additional studies to see if it actually will get brought to market, probably within the next year or two. So those are our controller medications. So primarily you've got inhaled steroids, long-acting beta agonists are going to be our two go-tos. You can also use like the glucotriene receptor antagonists or oral corticosteroids for short-term use. So for quick relief, short-acting beta agonists, albuterol, levoalbuterol, those are going to be the two that we use most often because they're the two that are available in the United States. Sometimes we'll counsel patients to use these before exercise to prevent that exercise-induced bronchospasm. One thing to keep in mind with that is when you're asking a patient about their use of their short-acting beta agonist, you don't count, like if you're counting up how many times a week they're using it, you don't count the times they use it before exercise. So if they tell you, I exercise 3 times a week and I use my inhaler before I exercise, but then other than that, I usually have to use it twice a week, then their count is really just 2. Does that make sense? So those are kind of like freebies. We do not, regular use or scheduled use of a short-acting beta is not recommended. Long-acting agents are far superior to short-acting agents in all the lung disease states. So if they're needing it very frequently, you need to go to something that's more controlling and not symptom relieving. Anticholinergics like ipratropium or tiotropium. We'll talk a lot about these when we talk about COPD, because that's primarily where they're indicated. But ipratropium, which is our short-acting anticholinergic, okay, we use it a lot of times in patients who come to the hospital with an exacerbation. We'll use it in addition to albuterol. So those are called AA nebs, atrovent albuterol nebs. So they'll both get put into the nebulizer, and we'll nebulize both of those medications at the same time in patients that are having severe exacerbations. There's actually some new evidence and some new studies that look at using tiotropium or Spiriva as a controller medication for asthma, in addition to like the steroid and the long-acting beta agonist. So that's kind of a hot topic. And it's currently recommended that if you have a patient that is poorly controlled with their asthma and they're on maximum therapy, that you should add Spiriva to that patient. Let's see. So when to use what? You guys want to take a break real quick? Yeah? Take about 5-10 minutes. Let's try to come back at the top of the hour and we'll finish this out real quick, okay? You swollen? There? Sore? That? It could be. Yeah. Are you swollen throat? I get mine that's swelling sometimes right front of my ear when I get sick. I mean, I don't mean that bad way, but you look like you don't feel okay. There's sometimes when I'm sick, like all the drainage is running to the side, and it's swollen and on the other side. So that might be. All right, guys, let's get started again so we can get through this then. Okay. So the question is when to use what, right? So when to pick what medication is what we need to talk about now. Okay. So like we said, asthma is a stepwise approach. That's everybody talks about stepping up or stepping down when they talk about asthma treatment. Historically, the steps have been differentiated by age categories. This is through the EPR3 guidelines. I'll show you at the end of the lecture what the GINA guidelines look like, which is actually a lot simpler and nicer, and so I prefer to look at those, but trying to give you as much information as possible, so in case I don't know what you get tested on in the board. So, and there's just small variations, like we said, between age groups depending on what drugs are approved for those age groups. So, children 0 to 4, 5 to 11, and then adults over 12 years of age are the next 3 slides. I don't expect you to be able to pick out therapy for children. I expect you to be able to know kind of this greater than 12 years of age situation, okay? So, and I know it looks scary and crazy, but it's not as bad as you think it is, okay? So for intermittent asthma, so all patients who have intermittent asthma, the preferred therapy is a short-acting beta agonist as needed. That's all they get, okay, per the EPR3 guidelines. For anybody that has persistent asthma, regardless of their severity, the focus is going to be on steroids. You see there, like, every step starts out with some kind of steroid, right? And depending on how severe it is how much you increase the steroid or add things to it. So like step 2 is a low-dose steroid, and then step 3 is either a medium-dose steroid or you add a long-acting beta to the low-dose steroid. So it's pretty self-explanatory. So, from step 3, if you had increased to a medium-dose steroid, that was your selection in step 2, or step 3, and you need to go to step 4, then you're going to add a long-acting beta to that medium-dose steroid. Okay? So it's just kind of like adding on and progressing up with more therapy as needed. Does that make sense? So you can step up or you can step down, but this is kind of an important take-home point here on the far corner. So before you make any changes, you have to assess adherence to their inhaler, make sure their technique is okay, and make sure that environmentally they're controlled. So, making sure that they haven't all of a sudden decided to become a bouncer at a smoky bar, and that's the reason why their asthma's out of control, is an important, key to making sure that patient has appropriate asthma treatment. Questions? So, again, this is kind of back to that severity without long-term control or medication. So, like we said, intermittent versus persistent. I wanted you guys to know these intermittent categories. So if they have intermittent asthma, like we said, a short-acting beta agonist as needed. If they have mild persistent or any kind of, persistent, they're going to get step 2, which is a low-dose inhaled steroid, right? And then if they have a more severe persistent asthma, okay, then they're going to get either a medium-dose steroid or maybe a low-dose plus a beta agonist. So you get to pick. It's like your choice what you want to do for those patients. There's lots of options, and they're all correct in their own way. So a mild persistent asthma patient might be somebody who has been having symptoms, a couple of times a month, more so than just those less than 2. But maybe they had a couple times a month they have symptoms, but they've not had, an exacerbation that's led to being put in the hospital or, made them miss work or anything like that. That might be a mild persistent asthma patient. If I told you somebody presented to the hospital for an asthma exacerbation, that's somebody who's, obviously moderately to severely persistent with their asthma, and they would need more aggressive therapy in the beginning. Okay, so once you have a patient on your controller medications, then you got to go back and you reassess their level of control. And typically this is done after a therapy change, usually anywhere from 6 to 12 weeks, depending on how severe the patient was when they presented. Sometimes even 2 weeks. If somebody presented and they had a, an exacerbation that landed them in the hospital and you changed their therapy, they're going to follow up with their physician or their practitioner within a week or two after they're discharged from the hospital. If it's like that first patient I told you that just kind of is having symptoms, but it's just persistent enough that they need some control, but they're not necessarily like missing work or having problems with their daily life, you might wait 6 weeks and follow up with that patient, okay? So like I said, you guys need to know these 4 things that indicate a patient is well controlled with their asthma. And so if they're well controlled, you're going to maintain current therapy. You might consider stepping their therapy down, okay? So you might say, okay, well, they're on a medium dose steroid. I might try to step back down to a low dose steroid and minimize their exposure and see if I can maintain that same level of control. If they're not well controlled and you assess all those things like adherence and environmental factors and technique, and all those things check out and you need to change their therapy, then you're going to step up 1 step. Okay, so you're going to increase the aggressiveness of their therapy and then revisit in about 2 to 6 weeks. And then those very poorly controlled patients, or the patients that have like an exacerbation, they might even get oral steroids, and they're going to get quite a bit more aggressive in their therapy at that time. Just some kind of tips about different special situations. We talked about the exercise-induced bronchospasms a little bit. Some of the non-pharm tips that you should know to counsel patients on are, if it's cold weather, oftentimes they can like wear a scarf or like one of those like robber masks over their face, like if they warm the air that they breathe, it helps, because it's all about how cold that air is when it passes through their airways. Recommending that they don't just go from standing still to sprinting, that they have like a warm-up period in their exercise to kind of slowly ease into that activity can also help. And also, they always need to carry their inhaler with them. The worst thing that can happen is they go for a long run and they get 3 miles away from their car and they have an asthma attack and they don't have any medication with them. So they need to always have it with them for use in case something happens. Surgery. Sometimes around the time of surgery, patients with severe asthma can actually, have a hard time with the ventilator, or can kind of decompensate around that acute stressful event. And so sometimes we may even give those patients that stress dose of steroids. So we might give them oral steroids or even IV steroids around the time of surgery to prevent like a deterioration in their lung function. And then we talked about pregnancy. So the way it works in pregnancy is about 1/3 of women get better with their asthma, 1/3 stay the same, and 1/3 get way worse. And it's just a crapshoot. You never know what's going to happen with that patient. And it could be different from one pregnancy to the next. So you can't really predict what's going to happen. So they need frequent follow-up and more aggressive therapy than you might expect. So this is a situation where we don't usually limit the medication we give to mom, as in the way of like steroids or beta agonists. One, because if they're inhaled, you have a very low systemic absorption, right? And 2, because if mom is not well controlled with her asthma, baby can be born at a low birth weight, can have premature delivery, and other like negative consequences that you don't want to have. Just kind of interesting fun fact, albuterol for your short-acting beta and then budesonide for inhaled corticosteroids are preferred in pregnancy because those are the ones that have the most evidence in those patients. Okay, so that's EPR3 stuff. Okay, now we're just going to quickly touch on some of the differences in the GINA guidelines and then kind of show you how much more simple this is. It doesn't matter which one you follow, it's going to pretty much end up being the same thing. It's the same treatment, it's the same therapy. I just think this lays it out a little bit better, and I don't want you to be that person that doesn't know what they're talking about if somebody brings this up and they're like, what dummy taught you asthma? You'd be like, she's no dummy. I learned about that. So, that's right. So for initial controller therapy, they kind of lay it out a little bit differently based on the level of evidence for those patients. The difference here is that if you look at this, so this top column, for example, symptoms less than or equal to 2 times a month, no nighttime awakenings, no risk factors for exacerbations, and no exacerbations in the previous year. That sounds a lot like the person I told you is well controlled, right, or intermittent asthma per the EPR3 guidelines, okay? So there's a very low level of evidence that these patients don't need a controller therapy. So what that basically means is We've always recommended for intermittent asthma patients that, a short-acting beta agonist should be enough for you. We have absolutely no evidence to tell us that's okay. That's just anecdotal expert opinion. There's no controlled trial that looks at those patients only receiving a short-acting beta agonist and outcomes. So we pretty much just made that up, okay? If you look at the second one there, if they have the same level of symptoms as above, but they have one or more risk factor for exacerbations, the GINA guidelines actually push for a sooner initiation of inhaled corticosteroids. So these guidelines, kind of like, you know how you had CHADS 2 and then CHADS VASC? And Dr. Stewart told you that CHADS VASC is more sensitive and picks up more patients that might benefit from anticoagulation. It's the same thing, okay? EPR3 is like the CHADS 2 score, and this is like CHADS VASC. It's going to pick up more patients who might benefit from controller medication and asthma. I'm so proud of myself. I have thought of so many parallels today between cardio and pulm. I should write a book. So, kind of you see here, basically in these three here, so symptoms or need for short-acting beta agonists greater than 2 times a week. That's where I told you that patients, per the EPR3 guidelines, that's a not well-controlled patient or a persistent patient who would benefit from inhaled steroids. But pretty much every patient before that also benefits per the GINA guidelines. So, the moral of the story is you would not be wrong if you started a patient on inhaled steroid, even if they met the criteria for intermittent asthma. Cool? Independent risk factors for exacerbations. I need you guys to be able to pick some of these out, okay? Because these are really important things that should trigger in your mind that that patient's at high risk for negative outcomes or for exacerbations with their asthma. So if they're using lots of their beta agonists, greater than 1 inhaler a month, how many inhalations are in a ProAir inhaler? 200. So if you use less than 2 inhalations a week, like you're supposed to, for controlled asthma off your short-acting beta agonist, how long should a albuterol inhaler last? 100 weeks, right? That's a long darn time. How many people come into your pharmacy like every month on the mark and refill their albuterol inhaler? That should be a trigger that there's something wrong with that patient. Not like, oh, that patient, they're crazy. There's clearly something wrong with their level of control. That's a patient that needs to be reassessed because an inhaler should last them way longer than that. Okay? Maybe they're black market inhalers. I don't know. But a patient who's well controlled shouldn't need an inhaler that often. So that should be a trigger that this patient has a risk factor for an exacerbation. If they don't have a good dose of an inhaled steroid or they don't have an inhaled steroid, that's a risk factor for exacerbations, okay? Exposures, that's another one. Comorbidities that are uncontrolled, or even if they're controlled, like we said, pregnancy alone is a comorbidity for an increased risk of exacerbations. ICU admissions, or then if they've had 1 or more severe exacerbations in the last year. Those are all some of the ones I would hope that you could pick out. We talked also earlier about the socioeconomic issues, that people who have a lower socioeconomic status, regardless of anything else, have an increased risk for poor outcomes with their asthma. I showed you guys this earlier. Like I said, that's for the GINA guidelines. Those are some of the questions they recommend that you ask patients to kind of assess their control. And this is the beautiful diagram that the GINA people put out. It's so much nicer than the charts I made from the EPR3. And you can see how much more simple this is. Oh, I forgot to tell you. On the chart about therapy, I don't expect you to know alternatives. I just want you to be able to pick out preferred regimens. So that stuff at the bottom that says alternative or alternate therapies, I don't really care that you know that for the exam. I want you to know that you can use leukotriene receptor antagonists for asthma, but those are all not preferred options. So you should be able to pick out those preferred ones and kind of step up and down that way. Sorry. So you can see here, this is so much nicer and much more simple than what I just showed you earlier. So pretty much almost everyone ends up on a low-dose steroid. There's really no good evidence for a short-acting beta agonist alone they say from the very beginning you can consider a low-dose inhaled steroid, and then you just kind of step up from there. So, gospel about asthma, things you're going to hear people say about asthma. I don't know why this comes up that way, but I guess I thought I was going to be creative and have things pop up. Long-acting beta agonists should be stopped as soon as possible. That's false. We already talked about that. That's the trial from ARC Internal Medicine that discontinuing long-acting betas actually leads to a worsening of symptoms in patients with asthma. So you can debunk that myth. Sparing the initiation of inhaled steroids for as long as possible, also false. Okay, I just told you in the GINA guidelines, there's more and more evidence to say that earlier initiation of inhaled steroids is actually more beneficial for patients. There's some evidence that the earlier you start a steroid, the greater improvement they have in their lung function, and over the course of their life, they have a lower cumulative dose of steroid use. So even waiting 1 to 2 years into an asthma diagnosis, over the course of that patient's life can increase the amount of steroids they need to almost double what they might need if you started it earlier. So it's almost like they're more sensitive, kind of like insulin. You know, there's a resistance that occurs over time with the disease. Kind of think of it in a similar fashion. The longer you wait, the more resistant that patient is to treatment with a steroid. Completely stopping inhaled steroids in adults is not recommended because there's an increased risk of exacerbations in those patients. And they only recommend stopping controller medications if the patient has pretty much been like even Steven with their asthma and had no symptoms for greater than a year. And even then, that's just expert opinion. There's no evidence to say that it's safe to take that medication away from that patient. Asthma action plans. This is what your extra credit assignment's all about, is completing an asthma action plan for a patient. The moral of the story is that every patient with asthma can benefit from an asthma action plan. Dash, dot, period, the end. Doesn't matter how well controlled or how poorly controlled they are. Doesn't matter what their age is. Every patient with asthma can benefit from being able to self-titrate and self-monitor their disease. Asthma inhaler adherence is almost impossible due to complex regimens and instructions. You'll hear people say that all the time. That's also false. Many patients, there's some inhaled steroids listed on there that actually have FDA approval for once daily use in patients with asthma. So they only have to take that dose once a day as opposed to twice a day. And then, like we talked about earlier, keep your eyes open for that labeling of these formoterol-based regimens so that patient just have one inhaler. That'd be super easy, right? Compared to what we do now anyway. Anticholinergics are not for patients with asthma. You'll hear that oftentimes, also false. Like we said earlier, there's some, this was from 2010, there was a trial that looked at patients that were on inhaled steroids. Some patients got added a long-acting beta, while other patients they added a tiotropium, a long-acting anticholinergic, and they found it was non-inferior. So either adding the long-acting beta or adding the anticholinergic, patients had pretty much the same outcomes. Currently, like we said, you would consider adding Spiriva to patients who are poorly controlled with their asthma, even though it's not labeled for that. There's enough evidence to recommend that it's safe, at least in those patients, to add a long-acting anticholinergic to try to control their disease. Let's see. This is another one of those kind of hot topics. There are studies that are going on all the time about anticholinergics and asthma. So I would say, again, probably in the next 5 to 10 years, this will be a medication class that's approved to treat asthma patients. Oops. This is a big one. Inhaled corticosteroids, stunting the growth of children. You guys heard that? Yeah. Okay, so it's kind of true, but there's a reason why it shouldn't really get that much credence, and you're probably going to have to educate some parents in the course of your career about this specifically. So there was a CAMP study that initially was done, like, I don't know, 20 years ago, okay? And it looked at patients. This is one of the first studies that told us that steroids should be the backbone of therapy for asthma, okay? So it looked at budesonide, 400 micrograms a day, metochromol, which we don't even use anymore. That's one of the mast cell stabilizers, okay, or placebo, okay? And they overwhelmingly found that budesonide did the best, okay? That was the best control. And they were all kids age 5 to 13, and they followed those patients on the same dose of medication or placebo for 4 to 6 years, okay? Then, 20-ish years later, something like that, they actually went back and found almost all of those patients, and they measured their adult height, okay? And kind of compared that to the placebo kids. They compared to the budesonide kids to see if there was a difference between those two groups in their adult height. And what they found was there was a slight difference, okay? So for the budesonide, the placebo group, there was an adjusted height difference of less than, or negative 1.2 centimeters, which is about a half an inch. Okay, so negligible. Wear some platforms. Get over it. Move on with your life, okay? The difference occurred usually in the first 2 years of treatment, but then, so kids, when they first started the steroid, their growth would slow, the velocity of their growth would slow, but then they caught up, and they started growing at the same rate as the kids who didn't take steroids, okay? Some of the things that people argue about the CAMP study is that it was a static dose of steroids, and it was a relatively high dose of steroids. So if those patients had been stepped down to a lower dose, would it have still shown the same results in the difference in their height? So the question is, how do you get parents to buy in if they come in and they say, I'm not going to give my kid this steroid because I don't want them to be, they need to be like the star student, the star athlete. I can't afford for them to be short. We're already a short people to begin with, kind of thing. So you got to think about like what you're going to tell those patients and how you're going to talk a parent into it if that's best for their kids. Acute asthma, this is simple, easy cheesy. Oxygen bronchodilators, which is pretty much your albuterol, potentially your ipratropium, adding that on. They're going to get high doses and they're going to get it more frequently. So typically, if somebody's taking a ProAir inhaler, what does a prescription normally say? How often and how many inhalations? Yeah, just all those things. You're correct. Yeah, so typically like maybe 1 to 2, 2 to 4, right, every 4 to 6 hours, something like that. That's a traditional prescription that you might see written for those patients if they need it. If somebody comes in and they're having an acute exacerbation with asthma, they may get up to 4 puffs every 20 minutes for the first hour. Okay, so they get lots, or they may get like a continuous nebulizer of that medication over the first hour. So they're getting lots, higher doses. What's the max dose you can give somebody of a beta agonist? When their heart beats out of their chest, you're giving them too much, right? It's all based on side effects. There's no toxic dose of a beta-2 agonist. I'm sure there probably is, but it would be really hard to get someone there. So you just keep giving it to them, okay? You just keep giving them that beta agonist as long as they're experiencing relief. And just monitor for side effects. Biggest side effect being tachycardia. Systemic steroids, this is a place where if somebody comes in with an exacerbation, we are going to use systemic steroids. The typical dose is, 1 mg per kg a day, but we tend to kind of max out at 40 to 50 milligrams of prednisone or a prednisone equivalent per day. Asthma is historically thought of as a steroid-responsive disease. So low doses of steroids can cause big differences in someone's ability to breathe or the inflammation in their lungs. So it doesn't take a lot of steroids, and you don't have to give it to them for very long. Okay, so this is something I would want you to know. All this stuff about steroids, you should commit this stuff to memory. Okay, because you need to know that it's lower doses. You need to know that for adults it's 5 to 7 days, and for kids it's 3 to 5 days is usually sufficient to treat their exacerbation, and then you don't have to taper those patients. Good? Okay. I didn't know that did that. I just put this on here for you guys to have. This comes from the GINA guidelines. It's kind of a flow chart about what happens if somebody comes in with an exacerbation, and it pretty much walks you through everything I just said, okay? When you would initiate what doses they would get, those kinds of things. And then on the second, it just basically continues the algorithm through. So those 2 slides are just one algorithm that are available in the guidelines. So I'll put that up there for you guys to have. Asthma action plans. Every patient should have one. We talked about that. And as a pharmacist, you need to know how to make one and how to interpret it, okay? Because I can't tell you how many times I've been in the clinic with residents, and they'll walk up to me and go, this patient just brought an asthma action plan in, and I don't know what to do with it. I don't know how to read it. I don't know where I should put where. So you may literally be the only healthcare professional available for that patient that knows how to read an asthma action plan, because there's just too much for other people to know sometimes. This is kind of an area that we can specialize in as far as making sure their medications are in the right spots. And unless the provider or the prescriber actually specializes in like allergies or asthma, they may not know how to put these together. This is a template. This is my favorite template. This is the one I like the most. It's hard to see on here, but all these are available with the extra credit asthma assignment. There are 3 different templates I've posted on there for you. You can pick and choose which one you like. The easiest thing to do is go Google asthma action plans, and like 15 different PDFs will pop up of different ones that you can use. There's even some really cool ones for like kids or for people who have maybe literacy problems. So it'll show pictures of like, you know, like these bubbly stick figures who were like, oh, I feel bad, you know, and it's like, oh, you feel like this, you should take this medication. And so it takes the words out of it, and it gives them visual pictures for what symptoms might trigger different medications. You can also, there are some technologies out there that you can actually take a picture of the inhaler that they should take when they feel that way. So that's really neat, especially for kids. There was a patient that not too long ago, it was a mom who couldn't read and had a baby that had asthma. And the baby kept coming in with exacerbations. And finally, the asthma educator at the hospital realized that it was because the mom didn't know what inhaler the baby needed when. And so she used that technology to like put the picture of the kid's inhaler, you know, down next to the symptoms, and that kept the baby out of the hospital because then mom knew what medication to use when. So you kind of got to get creative for some people. They're available in different languages, so just kind of, you know, go out there and look around. They're pretty neat. Peak flow meters, this is something that patients with asthma oftentimes will use to kind of measure their breathing. So we have spirometry testing. We'll talk about that a little bit tomorrow. But that's something that's done in the physician's office, and it's this big bulky machine, and you can't carry it around your pocket. Peak flow meters, they're cheap, they're very portable, they fit in your pocket. There's all different kinds of designs. And it's really designed to help people who are poor perceivers of their lung function. So there are some patients who don't perceive changes in their breathing very well. Like they have to get really, really bad before they're like, oh, there could be something wrong with me. And their lung function could fall dramatically before they start to experience those symptoms. So these are really good to help patients kind of track their changes from day to day. Usually we counsel patients that if they're going to use a peak flow meter, they need to measure twice a day, morning and night, to kind of catch those differences in their daily breathing, okay? And they'll kind of keep a log of their peak flow just like you would with blood sugars. And they'll bring that in to kind of show you differences. You should only have patients use a peak flow meter like to establish their personal best peak flow when they're at their best. So it's not a good time to measure peak flow around the time of an exacerbation or around the time of an illness. They need to be in tip-top shape to really get their best readings. And they use this kind of red light system to kind of indicate to the patient where they are in their respiratory abilities. So if they fall within 80% of their personal best, that's the green zone. It's like keep on keeping on. Just keep doing the same medications you're using. You're fine. If they're in the yellow zone, yellow zone, my mouth's dry, I'm sorry. Then they have some changes they'll make based on their asthma action plan. And this goes back, you might be able to see if they're kind of in the middle, but this is the yellow, green, and then red there at the bottom. So that would just kind of indicate to them to go to that section and read the directions and do whatever the directions are in that section. And then if they're in the red zone, that's the place where it's like, okay, you need to call for help. Like that's where you're in a place that you're at imminent risk of bad outcomes. Okay, questions? So if you have questions, I'm sure you will before it's over, but feel free to ask. Now here's the deal. I don't care what you do. This is up to you. It's the use of your time, but I'm going to tell you what tomorrow's expectations are, and you guys can decide how you use the next 30 minutes of your life, okay? Posted underneath, I think it's assignments and like graded activities, I think is the heading, is an asthma patient case exercise, okay? And there are 2 asthma patients, one on each side, with some questions that you're going to answer together with your group, okay? And tomorrow, we're going to have about, of our 50 minutes together, you're going to have probably the first 20 minutes or so to finish this up, and then I'll take one from each group. And that's how you get your grade, okay? So I'll need one of these completed from your group about 20 minutes into the hour tomorrow, and then we're going to discuss it as a group. If you want a physical copy for yourself, they're online. You can either type into it and make your notes or print yourself one off. But I've printed off copies for each group to at least have one. Okay? So I'm going to leave them here. If you want to discuss with your group and you want to spend the next 30 minutes working on it today so that you're ahead of the game tomorrow, that's fine. I'll be here. I'll hang out in case you want to work on it and have questions. Otherwise, you'll need to come in and sit in your groups first thing tomorrow and really get on this because you're not going to have a lot of time to finish it. Okay? Questions? All right, cool. If you want to leave, you can leave, but discuss with your group. These are laying here, and I'll be here for 20 more minutes at least if you want to stay and work on it.
Oh.